Welcome to the deep dive. Today we're tackling something a bit different. Non-atherosclerotic popliteal artery disease. So forget about cholesterol buildup for a moment. We're looking at two, let's say, less common culprits behind leg pain.
Right, especially in younger, active individuals, people who don't really fit that typical profile for vascular issues.
Exactly. We're diving into Popliteal Artery Entrapment Syndrome, or PAES,
It's PAES, yep.
and Adventitial Cystic Disease, ACD.
That's right. You know, while blocked arteries from atherosclerosis get most of the attention, it's really vital to consider these other possibilities.
Especially when younger, seemingly healthy people get leg pain with exercise.
Definitely. Missing a diagnosis of PAES or ACD can really impact their lives, so understanding them is pretty crucial.
Okay, let's get right into it then. Our goal today, and we're drawing on the fantastic knowledge in Rutherford's Vascular Surgery and Endovascular Therapy 10th edition,
A cornerstone text.
is to understand the key features of PAES and ACD. What makes them tick, how doctors diagnose them, and what the treatment options look like.
And those chapters in Rutherford's, they're really gold standards. They summarize decades of experience and research. It's like getting the distilled wisdom on these somewhat rare but significant conditions.
Okay, so first up, Popliteal Artery Entrapment Syndrome, PAES.
Yeah.
It sounds like something, I don't know, dramatic.
Well, it's interesting. The very first description of what we now recognize as PAS was actually way back in 1879 by a medical student, no less.
Wow, a student.
But the actual term Popliteal Artery Entrapment Syndrome, that wasn't coined until 1965.
Huh. Took a while to get the name sorted then. And it sounds like it might be maybe more common than we'd initially guess, especially for certain groups. The sources mention anatomical variations.
Yeah, autopsy studies found these sort of anatomical differences in about 3.5% of people. But here's the really key stat. PAES might be the cause in up to 60% of young folks who have claudication.
60%.
Up to 60%, yeah. That's leg pain with exercise. So for that specific group, you really have to consider it seriously.
Wow, 60. That really jumps out. Okay, the nickname jogging disease suddenly makes a whole lot more sense now.
It really does, because it affects so many active people. And while, it can occur across the board, kids, teens, women, the majority of reported cases, maybe up to 80%, are in men.
Young men, usually.
Typically in their early 30s, yeah. Median age around 32.
So often a younger man's issue. But the timing, this is interesting. You can be born with this anatomical setup, but it might take years, even decades, for problems to actually show up.
That's a really critical point. Even though the anomaly is congenital, meaning you're born with it, it's the chronic ongoing compression over time that usually leads to symptoms finally developing.
Right, it's not immediate.
Not usually. And it's not unusual to see symptoms in both legs, maybe about 30% of cases. And even if only one leg hurts, the anatomical variations might be present on both sides in like 2/3 of those cases.
So it could be lurking on the other side too.
Potentially. There are even rare reports of bilateral artery blockages or even entrapment affecting nearby arteries like the anterior tibial.
Okay, so let's get into the why. How does this actually happen? It seems to come down to how things develop before birth, right? In that space behind the knee, the popliteal fossa.
Precisely. It all traces back to embryology.
No.
The arteries in our lower limbs initially develop from two main sources, the axial artery down the back and the external iliac artery, which gives rise to the femoral artery down the front.
Okay.
Around 6 weeks of gestation, so very early on, this axial artery undergoes a bit of a rearrangement relative to the popliteus muscle, which is also back there behind the knee.
A kind of arterial reshuffling happening behind the knee then.
You could put it that way. There's a key structure called the bridging artery, the ramus communicans superius, that connects the femoral and axial systems.
Okay.
Then the part of the axial artery that runs deep to the popliteus muscle normally disappears, it regresses, and the popliteal artery as we know it forms from the fusion of other nearby arterial segments.
Got it. So like a bit of an arterial construction project happening in there.
Yeah.
And then the big calf muscle, the gastrocnemius, gets involved somehow.
Exactly. Initially, both heads of the gastrocnemius muscle start lower down, near the tibia, the shin bone.
Right.
As development progresses, they migrate upwards along the femur, the thigh bone. The medial head, the inner one, ends up being positioned a bit higher and slightly to the side of the popliteal artery, normally.
Okay.
Now, variations in the precise timing and extent of these movements, both the muscle heads migrating up and the artery developing, that's what can create the potential for the artery to get squeezed or entrapped.
Ah, so it's like a developmental timing issue. A slightly misaligned puzzle piece, maybe?
That's a great analogy. A slight misalignment between the developing artery and the migrating muscle.
And to categorize these different misalignments, there's a classification system.
Yes, the Heidelberg classification. It's become the standard way to describe the different types of PAEs. There are 6 main types.
6 types. Okay, can you give us the quick overview, the gist of each?
Sure, type I is sort of the classic form. A normally positioned medial head of the gastrocnemius muscle compresses a popliteal artery that, while it developed normally, is just deviated a bit too far inwards, medially.
Okay. Artery's a bit off course. What's type 2?
Type 2 also involves that medial deviation of the artery, but here the medial head of the gastrocnemius muscle itself has an abnormal attachment point, usually more towards the side or center of the lower end of the femur.
So in type 2, the muscle itself is attached in a slightly wrong spot, causing the squeeze.
Correct. Then type 3 is where abnormal muscle slips or fibrous bands compress the artery. These often come off the bony knobs at the end of the femur. It can also involve remnants of muscle behind the artery, or sometimes the artery even develops within the muscle mass itself.
Within the muscle. Wow.
Yeah. Or even rarer, a double origin of the gastrocnemius muscle can sort of wrap around and squeeze the artery. Types 1, 2, and 3 are often seen as representing a spectrum related to the relative timing of artery and muscle development.
That makes sense. Kind of a range of variations. What about type 4? That sounds different.
Type 4 is fundamentally different. In this case, that early embryonic vessel, the axial artery, persists as the mature popliteal artery, and because it stays in its original deeper position, it often gets trapped by the popliteus muscle or associated fibrous bands.
So it stays deep and gets caught.
Got it.
And type V.
Type V is when it's a double whammy. Both the popliteal artery and the popliteal vein are compressed by any of those mechanisms we just talked about.
Vein involved too.
Yeah, this happens in about 10 to 15% of PAE cases.
Ouch. That sounds particularly tricky, affecting both inflow and outflow.
Mm.
Okay, and finally type 6. This used to be called functional entrapment, right?
Exactly. In type 6, patients have all the typical PAES symptoms, like that leg pain with exercise, but standard imaging doesn't show a clear, fixed anatomical abnormality.
So what's thought to be going on there?
The current thinking is it might involve maybe a more laterally positioned attachment or hypertrophy enlargement of that medial head of the gastrocnemius. MRI scans done during stress maneuvers, like pointing the foot down, can sometimes show that muscle head moving more towards the midline and pressing on the artery during activity.
Ah, so it's more about how the muscle moves and interacts with the artery during activity rather than a constant structural squeeze in type 6.
Precisely. And our sources do mention even rarer cases involving slips from other muscles, like the lateral gastrocnemius head or the plantaris, but they're so uncommon they haven't really changed the main classification yet.
Okay, so we have these different types of anatomical or functional entrapment. Now, what's actually happening to the artery wall itself over time because of this chronic squeezing? What's the pathology?
Well, the constant or repetitive compression leads to a sequence of histological changes in the tissue. Stage 1 is basically fibrosis or scarring, just in the outermost layer of the artery, the adventitia.
Okay, just the outer layer first.
Then, stage 2, the fibrosis extends deeper into the middle layer, the media. This can weaken the artery wall, and that can lead to either poststenotic dilatation, a widening after the squeezed area, or potentially even a true aneurysm, which is a more significant bulge.
Weakening leads to bulging. And stage 3.
Stage 3 is more serious. The fibrosis reaches the innermost layer, the intima. When the intima gets damaged like this, the artery surface can become thrombogenic.
Meaning blood clots are more likely to form there.
Exactly, which can lead to blockage.
And interestingly, the severity of this damage isn't always directly related to how long the compression has been going on. That seems a bit counterintuitive.
It does, but that's what the evidence suggests. The body's response to this kind of chronic injury, the degree of scarring and damage, can really vary from person to person.
Okay, so what does all this feel like for the patient? What are the typical clinical presentations of PAES?
Well, as we mentioned, the classic picture is that young, physically active man with claudication leg pain with exercise. But the type of claudication can be a bit unusual, even paradoxical.
Paradoxical. How so?
It might actually get worse with just standing or slow walking, but then maybe improve with more vigorous exercise. Or it might come on almost immediately after starting activity, which is different from typical atherosclerotic claudication. These atypical patterns are a really key clue.
Atypical claudication definitely something for clinicians to flag. Any other signs or symptoms?
Patients might also report feeling coldness, or the leg might look pale, or they might feel numbness. And in types I through V, remember the tibial nerve runs close by, so sometimes it can get irritated or compressed too, causing paresthesia, that pins and needles, or tingling sensation.
Nerve symptoms too, potentially.
Potentially. And while most present with just exercise-induced pain, a minority, maybe 10%, might present with more severe chronic limb-threatening ischemia, CLTI, and even fewer with a sudden acute blockage.
Okay. And for type V, where the vein is also involved, what might that feel like?
That could present with more like calf cramping or symptoms that mimic a compartment syndrome. Think swelling, a feeling of fullness or tightness in the calf muscle.
Right. Now, the physical exam sounds like it's really crucial for suspecting PAES. What are doctors looking for?
Absolutely crucial. At rest, the pulses in the feet, the pedal pulses, are usually completely normal in PAES patients. That can be misleading.
Right.
But the hallmark finding, the classic sign, is that these pulses disappear, or at least significantly weaken, when the foot is put through specific maneuvers. Either passively bending the foot upwards towards the shin, that's dorsiflexion, or actively pointing the foot downwards, like pressing a gas pedal, that's plantarflexion.
Why do those movements affect the pulse?
Because those movements specifically tense the gastrocnemius muscle, which then further compresses the already potentially entrapped artery. It's vital for the examiner to check both limbs, obviously, and feel for this change. That disappearing pulse with specific foot movements is a very strong indicator for PAES.
The disappearing pulse with provocative maneuvers, major red flag for PAES.
Got it. And if PAES goes untreated for a long time, what are the consequences? Well, that ongoing compression leads to that progressive fibrosis, the scarring within the artery wall we talked about.
Right, the intimate gets damaged.
Exactly. The inner lining becomes more thrombogenic, prone to clot formation. Eventually, this can lead to thrombosis, a complete blockage or occlusion of the artery.
And that might present suddenly.
It can. Sometimes the first real sign is a sudden worsening of calf pain, maybe severe claudication, and the sudden absence of those pedal pulses in a young person who has no other risk factors for artery disease. Also, remember that poststenotic dilatation or aneurysm?
Yeah, the widening after the blockage.
That area can become a source of small blood clots, microemboli, that break off and travel downstream into the smaller arteries of the foot, causing further problems.
Okay, so a doctor suspects PAES based on the history, the symptoms, those provocative maneuvers on exam. How do they confirm it? What's a diagnostic workup?
Well, first they'll consider the differential diagnosis, other less common causes of leg pain that aren't atherosclerosis as laid out in Rutherford's. Then, non-invasive vascular testing is usually the next step.
Like putting someone on a treadmill.
Exactly. Exercise treadmill testing. Measuring the ankle brachial index, that blood pressure ratio between ankle and arm before and right after exercise, can show a significant drop in pressure in the affected leg if PAES is present.
Okay. What else non-invasively?
Duplex ultrasound is key. It uses sound waves to visualize the artery and measure blood flow. Specialists will specifically measure pressures, like in the posterior tibial artery in the lower leg, while the patient performs those same provocative maneuvers, active plantarflexion, passive dorsiflexion.
Trying to reproduce the pulse change while watching the pressures.
Precisely. And they'll also directly visualize the popliteal artery itself with the ultrasound probe while the patient contracts and relaxes their calf muscle. This needs careful technique, maybe repeating measurements, because the artery can actually move deeper or shift position during muscle contraction. They're trying to literally see that compression happening in real time.
So, catch the squeeze on ultrasound. But I think the sources mentioned that the accuracy of duplex alone can be a bit variable.
It can be. While some centers report high accuracy with duplex combined with these maneuvers, others have found a higher rate of false positives. So, if the duplex findings are strongly suggestive of PAES, further investigation is usually warranted to confirm.
And that often means moving on to angiography.
Angiography, yeah. Injecting contrast dye into the arteries and taking x-rays. It's still considered a mainstay investigation at many centers, and it has a high reported sensitivity, meaning it's good at picking up PAES when it's there.
What are they looking for on the angiogram?
Specific signs, like medial deviation, the artery being pushed towards the inside of the knee. A focal, short narrowing, or even blockage in the mid-popliteal artery. And often that poststenotic dilatation, the widening downstream. Finding at least two of these features is highly suggestive.
Can they do this with the leg in different positions?
Crucially, yes. They take images with the leg in a neutral, relaxed position, and during those provocative maneuvers, plantarflexion and dorsiflexion. This helps visualize the dynamic compression. It can also help differentiate PAES from our other condition, ACD, where the narrowing is usually visible even in the neutral position. Plus, angiography can show the status of the arteries lower down in the leg, in case emboli have occurred.
Makes sense. What about CT and MRI scans? Are they useful here?
Yes, definitely. CT and MRI angiography can be particularly helpful, especially if the popliteal artery is already completely occluded. They provide excellent anatomical detail showing the relationship between the vessel and the muscles, and can clearly identify those anomalous muscle insertions or fibrous bands causing the trouble.
Is one better than the other? CT versus MRI?
While some experts believe MRI might be superior to CT for evaluating PAES, partly because it avoids radiation. It's often preferred as the diagnostic test, especially in younger patients presenting with intermittent claudication.
Okay, so we've got a confirmed diagnosis of PAEs. What's the treatment plan?
For most patients who are symptomatic from PAEs, particularly types I through V, surgical intervention is generally recommended.
Surgery is the main approach.
For those anatomical types, yes. For type 6, the functional type, the decision for surgery really depends on how severe the symptoms are and how much they're impacting the patient's life and activity level.
And the specific surgery depends on the situation.
Exactly. It's tailored based on the specific anatomy found on imaging, how the patient presented, and critically, the condition of the popliteal artery itself. Is it still healthy or is it already damaged?
And intervening early sounds like a good idea if possible.
Absolutely. If PAES is caught relatively early, before significant arterial degeneration occurs, simply releasing the entrapping muscle or tendon that's called a myotomy or musculotendinous release can be sufficient.
Just freeing up the artery.
Exactly. It prevents further damage. The main goals of any PAES surgery are always 1. Relieve the entrapment. 2. Restore the normal anatomy as much as possible. And 3. Ensure good blood flow down the leg.
What about less invasive options like stents?
Endovascular therapies like angioplasty or stenting generally have a limited role in PAES because they don't address the root cause, the external muscular compression. The muscle will just keep squeezing the stent. There are some reports combining clot-busting drugs with later myotomy, but managing anticoagulation in young, active patients long-term isn't ideal.
Right. So for types I to V, where the artery itself is still basically okay, it's about that release procedure, the myotomy. How do surgeons do that?
There are two main surgical approaches: a posterior approach, making an incision on the back of the knee, or a medial approach from the inside of the knee.
What are the pros and cons?
The posterior approach generally offers more flexibility. The surgeon gets a wider view, it's easier to see everything clearly, identify the specific abnormality, and perform an arterial reconstruction like a bypass if it turns out to be needed unexpectedly.
So more versatile.
Yes. They make the incision, carefully protect the nearby nerves and veins, find the entrapped artery, and then completely divide whatever is causing the compression, usually the medial head of the gastrocnemius, or maybe an abnormal band. For types 3 or 4, they might need to release muscle attachments from the femur itself. Importantly, dividing these structures doesn't usually cause any significant long-term functional problems for the leg.
Okay. And the medial approach, when is that used?
The medial approach is often considered best for types 1 and 2, where the issue is primarily the position of the medial gastrocnemius head. Some surgeons feel it might allow for a quicker return to activity and potentially less morbidity, less surgical impact. Here, they divide that medial head from the inner side of the knee. It might be less suitable for types 3 or 4, where the anatomy can be more complex to sort out from that angle.
Okay. Now, what if the artery isn't okay? What if it's already thrombosed, blocked, or has significant damage like narrowing or that poststenotic dilatation or an aneurysm?
Right. In those situations, just releasing the muscle isn't enough. A bypass graft or replacement of the damaged arterial segment is usually indicated.
Using what for the graft?
Autogenous vein, the patient's own vein, usually the great saphenous vein from the leg, is preferred. Older techniques like trying to just clean out the blockage, thromboendarterectomy, or patching the artery didn't have great long-term results. Even minimal fibrosis seen during surgery might warrant replacement or bypass.
So bypass is often the way to go if the artery is damaged.
Often, yes. Surgeons might use duplex ultrasound during the operation, intraoperatively, to help decide. They measure blood flow velocities if the speed is too high through a narrowed segment, or if there's an aneurysm, bypass is likely needed.
And they release the muscle first.
Yes, relieve the entrapment first. Then they might resect, remove the thrombosed or damaged segment, and put in a short interposition vein graft. Or create a short venous bypass around the blocked segment, leaving the blocked bit in place but excluded from flow. For aneurysms or dilatation, resection and replacement with vein is standard.
Does the surgical approach differ here?
The posterior approach can be less useful if a long bypass down the leg is needed. The medial approach can be advantageous here because it allows easier harvesting of the saphenous vein from the upper leg and provides good access for connecting the bypass graft further down to the popliteal or even tibial arteries if necessary.
Okay. What about treating type 6, the functional type, where there's no clear anatomical problem?
Well, most experts still support surgical intervention if the patient is significantly symptomatic.
Even without a clear structure to cut?
Yes. The idea is still decompression. There's been some experimental talk about using botulinum toxin, Botox, to temporarily paralyze and atrophy the compressing part of the muscle, but that's not really standard practice or well tested yet.
So surgery for symptomatic type 6 usually means what?
Surgical decompression, again, via a medial or posterior approach. The goal is to carefully transect or resect the muscular part of the medial gastrocnemius head while preserving its tendon. It's crucial to completely detach it from its origin on the femur or intercondylar area. Again, intraoperative duplex might be used to check if the decompression has improved blood flow velocities.
And what if someone is found to have type 6, incidentally, on imaging, but they have zero symptoms?
That's a different story. Since arterial compression can sometimes be seen on provocative imaging, even in asymptomatic people, prophylactic or preventative surgery isn't supported. Just monitoring them, following up, is usually the best approach.
Same for the other leg if one side is symptomatic.
Pretty much. The asymptomatic contralateral leg in someone with unilateral PAES should definitely be investigated non-invasively, but surgery is seldom indicated unless or until symptoms develop on that side too.
Okay, so what kind of results do patients typically get after these treatments? What are the outcomes?
Generally quite good. For patients who only needed a myotomy because their artery was healthy, the results are usually excellent. They can often return fully to sports and previous activities, reinterventions are rare, and the artery tends to stay open long-term, like 10 years or more.
That's great. And for those needing bypass?
For bypass surgery using a vein graft when the artery was already abnormal, the long-term patency rates the artery staying open are still pretty good, reported anywhere from 65% up to 100% at 10 years in various studies. Short interposition grafts tend to do better than longer bypasses.
And those hybrid procedures?
Limited data there. One study reported around 60% patency at 5 years after combining angioplasty with myotomy, so maybe an option in select cases, but surgery remains the standard.
Okay, that gives us a really solid understanding of PAES. Now let's pivot to our second condition, Adventitial Cystic Disease, or ACD. This sounds quite different, cysts forming in the artery wall.
That's exactly right. A completely different pathology. The very first case report wasn't even in the popliteal artery. It was in the iliac artery, higher up in the pelvis, back in 1947.
The first popliteal case behind the knee was described a few years later, in 1954. Since then, maybe just over 700 cases have appeared in the medical literature.
And the popliteal artery is the most common spot.
By far. Accounts for about 80% of all reported ACD cases.
So popliteal ACD is what we mostly encounter, and it sounds even rarer than PAES.
Much rarer. It probably accounts for only about 0.1% of all cases of lower extremity claudication. So really uncommon.
And usually just one leg.
Almost always unilateral popliteal involvement. Only about 5 bilateral cases have ever been reported. After the popliteal, the next most common sites are the external iliac and femoral arteries, but it has been reported near other joint spaces too.
Mostly arteries, but sometimes veins.
Primarily arterial, yes, but it has been described occasionally in veins like the iliofemoral or saphenous veins.
And who typically gets ACD? Is the demographic similar to PAES? Similar in that it predominantly affects males, maybe a 5-to-1 ratio over females. But the typical age at diagnosis is a bit older than PAES, usually mid-40s on average, though women might be diagnosed slightly later.
Older than PAES, but still relatively young for arterial disease.
Exactly. And interestingly, it has even been reported in children as young as 5 years old. And just like PAES, the diagnosis is often delayed because these are younger people without the usual atherosclerosis risk factors, so it's not the first thing doctors might think of.
Right, the lack of typical risk factors throws people off again. And the true prevalence, how many people actually have it, is probably unknown since we only count symptomatic cases.
Precisely. We don't really know the true incidence.
Okay, the big question for ACD. What causes these cysts? Why do they form in the artery wall?
The sources mention several theories, but it sounds like it's still a bit controversial, maybe not fully understood.
It is definitely still debated. There are 5 main theories floating around, but none have, let's say, definitive proof, and some have limited scientific support. Okay, let's hear them. What's the first one?
The first is repetitive trauma. The idea is that chronic microinjury from repeated knee bending and straightening causes cystic degeneration in the artery wall, maybe some small bleeds, secretion of a substance called hydroxyproline, and eventually a cyst forms.
Plausible. Right.
Plausible on the surface, but it doesn't really explain ACD occurring in arteries not near joints subject to that kind of stress, or in very young patients who haven't had decades of repetitive motion. Plus, there's no clear correlation seen between athletic activity levels or age and developing ACD.
So the trauma theory has some holes. What's next?
The ganglion theory. This compares ACD cysts to simple ganglia, those common fluid-filled sacs near joints or tendons. Both contain hyaluronic acid.
Okay.
There are case reports of synovial cysts, which arise from the joint lining involving nearby vessels. So the proposed mechanism is that a synovial cyst might enlarge, track along a small vessel branch, and then implant itself into the adventitia, the outer layer of the main artery.
Like a traveling cyst.
Kind of. But the problem here is, when you look closely at the histology, the cell lining, and the fluid content, ACD cysts are actually quite different from typical synovial ganglia. ACD fluid has much higher hyaluronic acid levels, for instance.
So another theory with inconsistencies. Number 3.
Systemic disorder. This theory, proposed way back in 1967, suggested ACD might be part of some generalized systemic condition causing mucinous or myxomatous degeneration in tissues throughout the body.
Like a connective tissue disorder.
Potentially. But no specific systemic disorder has ever been consistently identified in ACD patients. And the fact that ACD is almost always localized to just one spot makes a systemic cause seem pretty unlikely. Bilateral or multi-site disease is extremely rare.
Right. Doesn't fit the pattern. Okay, that leaves 2 theories, developmental and articular.
The developmental theory, sometimes called cellular inclusion, is quite compelling. It suggests that during fetal development, when blood vessels are forming near developing joints, usually around 15 to 22 weeks gestation, some primitive mesenchymal cells, which have the potential to secrete mucin, might accidentally get incorporated or trapped within the adventitia of the developing artery.
Like leftover building material.
Kind of. And then later in life, perhaps triggered by something unknown, these misplaced cells might start producing and secreting the mucoid material that forms the cyst.
That sounds biologically plausible, a sort of developmental remnant causing trouble later. What about the last one, the articular theory? That sounds related to the joint.
Yes, and this one has gained more traction recently. It suggests a direct connection or communication between the knee joint capsule and the adventitial cyst in the popliteal artery.
A direct link. How?
Connections have actually been found, either during surgery or on detailed imaging, between the joint capsule and the cyst. The theory proposes that synovial fluid, the normal joint lubricant, might egress or leak out from the joint, track along a tiny arterial branch that supplies the joint, an articular branch, and then dissect into the adventitia of the parent popliteal artery, forming the cyst there.
Wow, like a leak from the joint plumbing into the artery wall.
Exactly. And proponents of this theory even suggest that finding and ligating or tying off this communicating channel during surgery, combined with just draining the cyst, might be a definitive treatment. That could potentially avoid the need for more complex arterial reconstruction, like vein grafts.
Interesting. That could simplify treatment.
It could. And this theory ties back nicely to both the ganglion theory, providing a pathway for fluid migration, and potentially the developmental theory, if that connection is an embryologic remnant. So it's an appealing hypothesis.
Definitely something researchers are looking into. Now, pathology-wise, what do these cysts look like up close?
Well, they're filled with that gelatinous mucoid material. Microscopically, the key features are a simple cuboidal cell lining within the adventitia, and very importantly, a complete absence of atherosclerosis in that segment of the artery.
No plaque buildup, just the cyst.
Right. Grossly, looking at it during surgery, the affected artery often looks enlarged, maybe described as sausage-like, and can be stuck down with adhesions to surrounding structures. The cyst itself is usually unilocular, one chamber, but can be multilocular.
And the fluid inside?
Usually clear or yellowish, but can be dark red if there's been some bleeding into it. The cyst becomes obvious once the surgeon cuts through the adventitia. Very rarely, cysts have been reported deeper, in the medial layer.
Okay, so a distinct entity within the artery wall. How does this manifest clinically? What is the patient experience with arterial ACD?
The typical patient, as we said, is often that young to middle-aged male. The key feature is usually a fairly sudden onset of calf claudication, pain with walking, often after only short distances.
Sudden onset is common.
Often described that way, yes. Though remember, it can occur at any age, even in kids. Symptom duration before diagnosis is often relatively short, weeks to months, and almost always just one leg.
Any other quirks to the symptoms?
The claudication might sometimes resolve temporarily and then recur, or it can progress rapidly. Patients might also notice a prolonged recovery time after stopping exercise. It takes longer for the pain to go away compared to typical claudication.
And you mentioned it's less likely to cause severe limb ischemia compared to atherosclerosis.
Generally, yes, progression to CLTI is unusual, probably because it's usually a focal problem, the patients are younger, and the arteries above and below the cyst are typically normal. But the claudication itself can become very limiting.
So the cyst might be growing for a while before it causes symptoms.
That seems likely. It probably enlarges slowly over time until it starts significantly compressing the lumen, the inside channel of the artery. This causes a functional occlusion narrowing without necessarily a blood clot. In these cases, just evacuating the cyst fluid can sometimes restore patency.
But if it goes on long enough,
Prolonged compression can eventually lead to thrombosis, clot formation, and a fixed, permanent occlusion. But about 2/3 of patients actually present with just stenosis, narrowing, rather than complete occlusion.
okay. What about the physical exam for ACD? Any specific signs?
The pedal pulses might be normal, or they could be diminished. Sometimes a brute, that whooshing sound, can be heard over the popliteal fossa with a stethoscope.
And the key sign to differentiate from PAES.
Right. Instead of pulses disappearing with ankle-foot movements, in ACD, the pulses might disappear or weaken significantly with sharp flexion of the hip and knee. This is called the Ishikawa sign. It suggests that bending the knee kinks the artery over the cyst, causing functional stenosis.
Ishikawa's sign for ACD, provocative maneuvers for PAES. Got it.
Exactly. And while spontaneous resolution, maybe from cyst rupture, has been reported in rare cases, it's definitely not typical. Recurrence after apparent spontaneous resolution has also occurred.
Okay. And briefly, what about venous ACD? You said it's rare in the legs.
Extremely rare in the lower extremities. When it does happen, again, mostly young males, sometimes children, usually in the iliofemoral veins up in the groin thigh area, not the popliteal vein.
How would that present?
Often discovered during a workup for a suspected DVT, a deep vein thrombosis, maybe painless leg swelling. Doctors should consider it if a venous duplex ultrasound shows signs of extrinsic compression, or if a venogram shows a filling defect that looks like something pushing on the vein from outside.
And treatment for venous ACD.
Optimal management isn't totally clear because it's so rare, but most advocate for operative exploration open the vein, venotomy, evacuate the cyst, and excise the cyst wall to try and minimize recurrence, which has been recorded at around 11–12%.
Okay. So for diagnosing the much more common arterial ACD, what's the process?
Well, again, consider the differential other cysts, even rare sarcomas. Ankle brachial indices might be normal at rest, but drop after exercise, pointing towards an arterial issue.
And imaging.
The approach has really shifted over the years from primarily angiography to cross-sectional imaging. Current recommendations usually favor duplex ultrasound first, followed by either CT or MRI for confirmation and planning.
What does duplex show in ACD?
It's a great initial tool. It can show the cysts, their size. The key diagnostic features are elevated blood flow velocities through the narrowed artery segment, combined with seeing that extraluminal compression from the cyst itself. Sometimes you can even see a fine, bright line pulsating between the cyst and the artery lumen.
And it helps rule out an aneurysm.
Yes, because an aneurysm would have flow within the dilated sac, whereas the cyst doesn't. Ultrasound is also really valuable for postoperative surveillance, checking for recurrence or stenosis.
And angiography. Less used now for diagnosis.
Largely replaced for primary diagnosis, yes. It might show complete occlusion in up to 1/3 of cases. Or in others, those characteristic narrowing patterns, the eccentric scimitar sign or the concentric hourglass sign.
Scimitar or hourglass. Descriptive.
They are. You can see those on CT/MRI too. But angiography is less sensitive overall, might miss some stenosis, and doesn't show the cyst wall or surrounding tissues well. Eccentric stenosis without clot or dilatation is pretty specific for ACD when seen, though.
So CT and MRI are now more central to diagnosis and planning.
Definitely. CT angiography is increasingly used. It's great for differentiating ACD from PAES or aneurysms, especially if there's clot involved. It clearly shows the cyst size and relationship to other structures.
And MRI?
Also frequently used. Big advantages are no radiation and often no need for contrast dye. It gives excellent soft tissue detail, really clearly delineates the cystic involvement in the artery wall, which is crucial for planning surgery. Specific sequences like T2 weighted or gradient echo are often recommended.
So bottom line for diagnosis.
Most experts now recommend cross-sectional imaging, either MRI or CT, for definitive diagnosis and surgical planning. Duplex remains excellent for the initial evaluation and for follow-up, and newer things like intravascular ultrasound, IVUS, or optical coherence tomography, OCT, looking from inside the artery, might become more important in the future.
Okay, diagnosis made. How do we treat ACD?
Since it's rare, recommendations often come from single-center experiences rather than large trials, but treatments basically fall into two categories. Non-resectional methods for when the artery is narrowed but still open, non-occlusive stenosis, and resectional methods for when it's blocked or badly degenerated.
Let's start with non-resectional options. What are they?
Well, percutaneous transluminal angioplasty, PTA, ballooning it open with or without stenting, that's largely been discarded. It just doesn't work well long term. The cyst causes recoil and restenosis.
So ballooning is out. What else?
CT or ultrasound-guided percutaneous cyst aspiration, sticking a needle in under guidance to drain the fluid. This has shown some promise, at least short-term.
But potential downsides.
Yeah, it can fail if the cyst is multiloculated or the fluid is too thick, and recurrence is common. There are weird reports of spontaneous resolution after a failed aspiration, maybe from disrupting the wall, but rapid recurrence is also well described. So it's generally reserved for patients who aren't surgical candidates, but agree to very close surveillance and likely reintervention.
Okay, so aspiration is limited. What's the main non-resectional surgical approach?
That would be operative cyst excision and evacuation. Go in surgically, usually posterior approach, patient prone. Expose the artery. Incise the adventitia over the cyst, drain the gelatinous stuff, and ideally remove the cyst lining. This is often sufficient if the artery is just stenosed by the cyst.
And the resectional methods. When are they needed?
They're preferred if the artery is thrombosed, completely blocked, or if imaging or intraoperative findings show extensive arterial degeneration from the chronic cyst presence.
And that involves removing the artery segment.
Yes. Again, usually a posterior approach. Remove the disease segment and then reconstruct the artery, typically with an autogenous vein graft or sometimes a prosthetic graft.
So the choice really hinges on whether the artery is open or blocked.
That's the key determinant, luminal status. Non-resectional aspiration or operative evacuation excision can be considered for non-occluded arteries, offering good short-term results. Resection, excision and reconstruction bypass, is generally advocated for thrombosis or significant degeneration.
And how do the outcomes compare? What about recurrence?
Recurrence is a known issue with all methods, unfortunately, though it seems less likely after complete resection.
What are the rates like?
Cyst aspiration has the highest recurrence, maybe 10–30% at around 15 months follow-up. Operative cyst evacuation alone might have failure recurrence around 15%. Resection seems lowest, maybe 6–10% failure or recurrence.
And bypass outcomes.
Revascularization with autogenous vein after resection generally has the highest long-term success rate for keeping blood flowing. But interestingly, recurrence of the cyst within the vein graft itself has even been reported.
Wow, it can come back even in the graft.
Rarely, but yes. And endovascular therapy, angioplastenting, just has high short-term failure rates for ACD. So the bottom line is indefinite, periodic, postoperative duplex surveillance is necessary after any treatment for ACD because of that recurrence risk.
Okay, we have covered a ton of information on both PAES and ACD. Just to help everyone listening really cement this, can we quickly recap the key differences between them?
Absolutely. So PAES, typically a younger, athletic male, leg pain specifically with exercise. Key exam finding is pulses disappearing with those specific ankle-foot provocative maneuvers. The cause is muscle or bands compressing the artery from the outside.
Right. And ACD.
ACD, typically slightly older male, maybe more sudden onset claudication, might have that Ishikawa sign, pulse is gone with hypneflexion. The cause is a cyst within the artery wall compressing the lumen from the inside. different mechanism, different provocative sign.
Got it. So both are really important non-atherosclerotic causes to consider in younger patients with leg symptoms, especially when they don't fit that typical vascular patient profile.
Exactly. Keep them on the differential diagnosis list.
And imaging, as we've discussed, is absolutely critical. Getting the right images, duplex, CTA, MRA, is key for diagnosis and planning the right treatment.
Couldn't agree more. Accurate imaging is paramount.
And the good news is, although these conditions can cause significant issues, with the right surgical management, the outcomes are generally pretty good. Though, as you stressed, patients with ACDE really need that long-term surveillance for recurrence.
That's right. Good outcomes are achievable, but vigilance, especially for ACD, is key.
This has been a fascinating deep dive, and it leaves me, and hopefully you listening, with a final thought. Given these different proposed causes, developmental quirks for PAES, maybe joint fluid leakage for ACD, how might future research focus on finding more targeted, maybe even preventative strategies for these conditions down the line?
That's the million-dollar question, isn't it? Understanding the fundamental etiology better could definitely open doors.
Absolutely something to think about. Thank you for joining us today on The Deep Dive.